Thanks to all of you for being here and for your interest in this topic. And for those of you who aren't particularly interested in this topic, I certainly hope you are as the presentations continue this afternoon. It's an absolute pleasure to be sharing this stage with my two colleagues. So in terms of learning objectives, you can read them for yourself, but let me explain a little bit about an issue that came to me when I was a medical student and that has persisted and motivated a lot of the work that I've been doing since then. It became clear to me that when the demand for health services, doctors or otherwise, is greater than our supply of them, we have a luxury of doing our job by taking whoever comes knocking at our door. There are always people who are coming knocking at our door. But those who knock the loudest are often those with the best access. There are many people who don't come knocking because they're working 2 or 3 jobs, because they can't afford transit or childcare to get to appointments. And these are familiar stories to many of us. Many patients are so busy meeting their basic needs which means that if we do not look beyond our doors to those who don't come knocking, we often miss those who may be needing our help the most. And I believe that this practice of first come, first serve medicine, where we are extremely busy clinically with all of the clinical activities that we do in a day, can actually be discriminatory if we don't look at the populations we're serving. And we do have the ability to use our clinical lens to see beyond to some of the solutions. So to start off, I want us all to become familiar with an important term, which is the social determinants of health. I hope that this term is familiar to most of you. But just as a recap, these are the social and economic conditions that affect both individual and also the health of populations. What continues to astound me and puts our biomedical focus and practice in perspective is that 50% of morbidity and mortality can be explained by social determinants of health: income, early childhood, disability, social supports, gender, education, employment. And these are all represented by the red figures in the slide. And in comparison, 25% of health outcomes are determined by access to healthcare, where we certainly spend a lot of deserved time and attention. But looking proportionally at the impact of social determinants makes it a lot more difficult for us to ignore the importance of these issues. Now, what does this look like for patients? These 2 quotes on this slide are from JAMA and from CAIHI, and they summarize what I feel is an absolutely indisputable evidence base that poverty leads to poor health outcomes. We might be quick to blame patients for making bad choices, for eating poorly or smoking, or not seeking medical attention for chronic health conditions. However, research indicates that this explains only a minority of the connection between social factors and health outcomes. We also must ask if people are in fact making bad choices, if they have a choice at all when access to resources and support is limited and when stress is very high. I love the diagram on this slide on the top left because it helps me understand and visualize the impact of poverty on health. The slope becomes steeper when challenges due to employment, inadequate nutrition, education, all of the health determinants are greater. That's a steeper slope for the heavy black ball of health hazards to slide down and pick up tremendous momentum along the way. And it requires more resilience and support in the form of preventive action to counter its increased weight. This diagram I come back to again and again to help me understand what I can do clinically. But now let's go to our provincial context. What does poverty and the impact of social determinants look like in BC? BC does not perform well, and if you go to worstincanada.org, you will see that our poverty rates are the worst in the country, and ever increasing, now even faster than those in the United States. Poverty in BC has a tremendous cost. The social costs, the health costs, the costs of lost productivity are tremendous, estimated at about $8 to $9 billion annually. Those who advocate for a poverty reduction plan, which help to defray some of the risks faced by people living in poverty, is estimated at far less, $3 to $4 billion a year, if we had the political will to address this issue. The trend that we see in employment is very important to note, and the overall trend really is happening since the recession began in 2008, when we had a net job loss of somewhere between 600,000 and 700,000 jobs, And that hasn't, all the employment efforts that have happened since then have only affected that very minutely, by less than 10%. So we still are facing a very similar rate of job loss, especially in full-time work, and especially for young people in Canada who have twice the levels of unemployment than older people in Canada do. So the overall economic picture for employment is quite grim. In addition, this trend toward austerity budgets means that we're losing social services, the services that people living in poverty, facing unemployment, desperately depend on. And last year, in the budget update, the BC government announced a further $130 million in cuts to public services over the next 3 years. So these are pretty dire circumstances. This slide shows the poverty rates in BC, specifically child poverty. I'm glad that this map put out by the Canadian Centre for Policy Alternatives has included poverty rates in Indigenous and non-Indigenous children. Because on the bottom right, you see a clip from a CBC News piece that quotes the tremendous and highest in BC child poverty rates, yet those in Aboriginal communities are far higher than those experienced by non-Aboriginal families. So on this slide, I want you to start by looking on the right side. The right side shows the poverty lines. In that kind of blue and green chart on the top right, we can see the poverty lines as calculated by 3 different measures. But what we can see in the left column is that from 13.6 to 17.3% of people in BC are living below the poverty line. The poverty line is listed in the middle and right columns. The middle column, the green text being for a family of 4, and a single person being in the blue text on the right. Below that, we see the current rates affecting those living in poverty in BC. The minimum wage is simply not enough to lift people above the poverty line. So people are working and remaining living in poverty despite working full-time jobs in the minimum wage in BC currently. The welfare rate of $610 a month, I just have no idea how people even live on that amount in this province, and in particular in Vancouver. And the disability rate for people with substantial medical conditions, which cause even greater lifestyle costs associated with them, get slightly more. None of these rates are sufficient to allow people to live above the poverty line. On the left side of this graph is a map of living wages. The Living Wage Campaign has calculated what it would cost to meet basic needs living in various communities in BC. This does not include any money for debt repayment or savings, only basic needs including food, clothing, shelter, transportation, childcare, MSP premiums, education expenses, and a very small monthly contingency fund. And these are the wages that would be required to allow people to meet those basic needs in this province. As we can see, the minimum wage in Vancouver is currently half of what would be a living wage in this province. We are trapping people in poverty, employed patients included. This map shows us food bank use, and I think the take-home message here is that a tremendous population in Canada depends on food banks monthly in order to make ends meet. In BC, 94,000 people use food banks monthly as part of their regular nutritional expense and a way of meeting their nutritional needs. A third of those are children. And although we saw a very slight decrease in the last available year for statistics from 2012 to 2013, we saw a 20% increase from after the recession in 2008 to 2013. So the overall trend is increasing food bank use, which is a sign that we're not doing something right. So a question, I suppose not so much to come up to the mic and answer right now, but to think about. How does poverty and its impact on health affect those living above the poverty line, which presumably are most of the people in this room? The poverty line. Let's talk about the poverty line. How does the poverty line affect those living above it? The surface explanation that I don't like to give, but that I will give to capture your attention perhaps, is that with more poverty comes more illness. We already saw an introduction to that concept. And with more illness comes more demand for healthcare, which is in limited supply. And so we can see if somebody isn't accessing the healthcare services they need in the community, for example, a homeless patient, and then they seek care inappropriately in the emergency department simply because the community resources are not there, then access to emergency care services are decreased for those who are seeking appropriate care in the emergency department. So it affects all of us. But I don't like giving that superficial example because it's the back to basis example, but it goes a lot deeper. On the left is a snapshot of the title of a fabulous book by Richard Wilkinson and Kate Pickett called The Spirit Level: Why Equality is Better for Everyone. The evidence is absolutely overwhelming, and I encourage you to look at it because it will open your mind. Societies with the greatest income inequalities across the population spectrum have worse health outcomes and shorter life expectancy when compared to countries with less inequities, which means that income inequity affects everyone along the spectrum. Richard Wilkinson and Dr. Michael Marmot, both in the UK, are two researchers and champions of this overwhelming population evidence. And snapshots of their publications are here, and there's one on the next slide as well. In this graph, we see the life expectancy in light green and disability-free life expectancy in dark green. Moving from left to right indicates less neighborhood deprivation or increasing wealth from left to right, which we can see is associated with higher life expectancy as we move along the spectrum to greater wealth. Similarly, this graph shows mortality of men in England from 1981 to 1992 by social class and employment status. These are old statistics, but these were some of the fundamental studies that were done showing this trend of income inequality as it relates to health outcome. And what we can see here is that every step of decrease in social class translates to worse mortality, with class 1 on the left of each of the graphs being the highest social class, and class 5 on the right side of each of these two graphs being the lowest social class. The dark green graph shows mortality for employed men compared to the light green graph for unemployed men. So the social gradient for mortality repeats itself, not only across social class, but mortality is higher for unemployed compared to employed men. What does this look like in Canada? The gradients in health, as we have seen, are directly related to gradients in income. So is there even a poverty line? It appears, looking at Canadian statistics, that there isn't. Just like we saw with the last graph, that there was stepwise changes or continuous changes along the full spectrum of income. On the left-sided graph, you don't need to see the small text. Only note that we see rates of illness from multiple categories: arthritis, hypertension, cataracts, migraine, asthma, heart disease, incontinence, bronchitis, GI ulcers, cancer, diabetes, and stroke are all higher in the black group, which represents low income, compared to the gray group, which represents higher income. On the right, however, instead of looking at high and low income groups, we can see that the poverty line is essentially a false label we impose on the phenomenon of a gradient of poverty and health. For both women and men, the blue and pink groups, we see that rates of disease drop steadily as income increases. And this is the conclusion across the board. We see it consistently in population health research, showing that every step along the income gradient matters when it comes to health outcomes. If you make $100 more than your neighbor monthly, you will have better health outcomes. If I make $100 more than you, I will have better health outcomes, and so on. Of course, population trends do not translate directly to individual level outcomes. There's tremendous variation on an individual level, but the population evidence for this is absolutely overwhelming. And so the poverty gradient is much more important than, in fact, a poverty line. And that's why it should matter to all of us. Now, I hope I've convinced you that poverty matters. So what do we do clinically about this, which is the question before us today? Here's a brief case study. Harriet, a 58-year-old woman who immigrated to Canada from Jamaica. She's been out of work for 15 years. She has an extensive medical history, including chronic renal disease. And your team has done your best to optimize care for her, both physically and for her mental health too. But you're not seeing her care improving. How should we use our time with Harriet? There's always more investigations to be done. There's always something clinically that we can do. So I'm going to talk about two levels, level 1 and level 2, of how to address poverty in clinical settings. In 2011, I published a paper in which we validated questions that clinicians could use to screen for poverty. We tested questions related to common determinants of health: food, housing, and job security, which are essentially surrogate markers of poverty. But we really wanted to know, could we ask patients directly about poverty? If we can take a sexual history, surely we can take a poverty history. And qualitative comments provided by study participants confirmed this. If it was important to the patient, it was important for the doctor to know. In fact, 85% of low-income respondents in the study felt that poverty screening was important, and 67% of low-income respondents felt they were comfortable speaking to their GP about issues of poverty. The best performing question in this study, which isn't the most important conclusion, but let's talk about the question first, is, do you ever have difficulty making ends meet at the end of the month? The sensitivity and specificity are listed. An adapted version of this question was recently published by the Kootenai Boundary Division of Family Practice, which is, do you have enough money for food after paying your monthly bills? But no matter how you ask the question, income should be part of a patient's social and medical history. I will talk about interventions following screening in a moment, but keep this question in mind. That's why I put it on this slide, and that is asking patients if they've filed their tax return. This is the one gateway step for patients to access multiple services and income support programs that will help increase their income, and there are community tax clinics that can help with this. So add it here as an additional question to keep in your pocket. The research study coincided with a movement, one of those coincidences that make me grateful for where I am in my career right now in primary care, which is this trend to recognizing the overwhelming evidence for the impact of poverty on health outcomes, and the development of tools to help health providers get involved in addressing this very important topic. And there's very many tools that have been developed just in the last 5 years on this subject, and I'll briefly go through them. This tool was a pioneering poverty tool that was developed by my colleague and friend Gary Block in Toronto in collaboration with a group that I used to work with when I was in medical school, the Health Providers Against Poverty, and also the Ontario College of Family Physicians. The root trend in all of these poverty tools are to first screen for poverty issues, consider the risk factors relevant to each patient that poverty brings them, and then to intervene, to actually do something about it. Another tool is the CLEAR collaboration based out of McGill, led by Dr. Ann Anderman, and they've created a similar tool with more detailed guidance for healthcare providers and how exactly you can go about addressing this. Instead of the nuts and bolts, it does give you a little bit more guidance information. I would encourage you to look at it. Vancouver Coastal Health has developed a tool specifically for seniors, which may be relevant to a lot of patients with renal disease. And Reach Community Health Centre in East Vancouver has implemented a program I will mention later that systematically addresses social determinants of health as part of the office visit. And they also have a pamphlet that goes along with it. But the program is worth noting, and we'll discuss it in a moment. Probably most important for you to note, and I've included the website here, and I'll repeat the website in a moment, is a tool recently developed by the Kootenai Boundary Division of Family Practice, which is specific to BC. So a lot of the resources that patients will be eligible for to help supplement their income through tax programs and other programs are specific provincially. There are some federal programs as well, and these are all outlined on this tool. So I won't go into tremendous detail about this today, except to point you to the tool and give you resources. It's very clearly laid out. Again, it follows the same stepwise process. Inquire about poverty, recognize risk factors, and some of the evidence for increased risk specific to health conditions is included in the tool. And then depending on a patient's demographic and eligibility, for example, for seniors, children's, or First Nations patients, there are different programs for which they are eligible. These are all outlined and available to you. All of these three tools are worth looking at. I've included the website in these slides. You can also Google the titles that I've put here. If you Google Kootenai Boundary Division tool, OCFP tool, they easily come up online and they're all downloadable for free. Have a look at them. It's more clearly laid out than I need to do today for you. On the left is a Toronto Star article that actually cited the income increases that you can see once eligible patients apply for tax-based poverty programs that help alleviate the burden of income insecurity. And we can see that some of those programs do in fact push people just above the poverty line. Not like the poverty line matters as the most important factor, but just to show the concrete benefits that we can have for patients to actually increase their income and ability to afford some of their basic needs. Dr. Gary Block and I, in the last 2 years, worked with the Canadian Medical Association to develop an online continuing education module for physicians on how to address poverty in clinical settings. It's available to all CMA members on the CMA website, which is listed there. And it's a 2-hour CME module, which gives continuing education credits, which also teaches us how to do this work. But there's a bigger question that I wanted to talk about today, because the tools are available, but there's something else that we need to think about. I went on to do a second research study, which I recently completed, to look at how we can address poverty in primary care. This is not a practice that we do very well. It's not a practice that we do very often. And so I wanted to know what our role is, what barriers and facilitators there are to doing this work. And I asked patients and community advocates and health providers of all stripes, and we all sat around the table together, and it was a wonderful experience. And there's a couple themes that came out of that I want to share with you. Very important thing, we must be aware of the shame and power dynamics that are involved in patient care, especially when it comes to issues of marginalization. Health providers are in a position of power, and yet they can feel powerless if they can't help the patient. Patients described this dynamic in pretty dramatic terms. One patient says, "It's about resentments maybe. Here I am struggling to feed myself, and here's a person who makes $150,000 a year who's supposed to give me the answer in 15 minutes about a life that she can't understand." The doctor thinks they can read your mind, but unfortunately they cannot. But it is hard trying to admit that, being embarrassed knowing that we're a lot lower than everyone else. The research showed that there was a cycle of neglect of social determinants of health that occurs in clinical environments that's based on a prioritization of biomedical issues over social issues. This leads to a don't ask, don't tell policy, which perpetuates this cycle of neglect of social determinants. Biomedical concerns are more important, which leads to unspoken truths that are embedded in power and shame dynamics. We don't feel safe talking about issues of poverty and marginalization. And then judgmental attitudes that follow from that these issues aren't relevant or there's nothing I can do about it. And that is an ongoing judgment that we're making as professionals to not address these issues. But there are solutions. Patients described family physicians one patient said, who could see when I was starting to slide before I slid, because they deal with you on an ongoing basis, reflecting the role of relationship-based and longitudinal care, which has great potential to address these issues. Another participant described feeling welcoming vibes in his family doctor's office. He felt valued, he felt liked, and he felt respected. And they all expressed, in every focus group that I ran, that they preferred that health providers were upfront and honest about issues of concern. And that moves us on to level 2 of addressing poverty in clinical practice, which is addressing underlying issues. Let me cite some related evidence that I find just fascinating. This was a study published in the American Journal of Sociology in which pairs of young, well-groomed, well-spoken college men with identical resumes applied for entry-level jobs. There were 2 teams were black and 2 were white. In each team, one person said that they had served an 18-month prison sentence for cocaine possession. Of the participants in this study who received a callback for a job interview, you can see that white men received far more callbacks than black men. But what's interesting is, white men with a criminal record received more callbacks than black men without a criminal record. This has been studied in the form of everyday discrimination. There are validated questionnaires and tools that study a lot of the power and shame dynamics that I touched on very briefly with respect to my qualitative research. And these are captured in various questionnaires with some of the items you can see on the slide. What is interesting, beyond the link between social determinants of health and poor health outcomes, is that everyday discrimination was positively associated with multiple qualitative indicators of worse health outcomes. Coronary artery calcification, C-reactive protein, blood pressure, lower birth weight, cognitive impairment, poor sleep, mortality, and visceral fat were all higher in people who had higher daily perceived discrimination. A fascinating study was published in the Canadian Medical Association Journal last year. Researchers played roles of high and low income patients with and without a chronic health condition and who are seeking a GP. 22.6% of the high-income patients were offered appointments, as opposed to 14.3% of low-income patients. On a positive note, 23.5% of patients with chronic health conditions were offered appointments, as opposed to 12.8% of those without chronic health conditions. So we are providing care to people with chronic health conditions, but the bias towards delivering care to people with health conditions did not outweigh the effect of social status on access to care. Higher socioeconomic status patients still received preferential access for care. But you might say, and I sometimes say this to myself, I'm not judgmental. I understand issues of marginalization and vulnerability in patients. Gosh, this is my area of interest. But there are some factors that are important to identify. And this very much goes back to the sociological research about human behavior, which is that when one holds a negative stereotype about a group and meets someone who fits the stereotype, he or she will discriminate. Conclusive evidence demonstrates that stereotypes are activated automatically without intent, and these are unconscious processes, and that's why it happens. We are not aware of the activation of processes of discrimination and judgment. And many cognitive processes always confirm our expectations. What we expect of a patient, if we hold a judgment or an expectation for a patient to be non-compliant, it is likely that the situation will evolve to fit our expectation. So important conclusions from my research and from related research is this first conclusion was the biggest one that came out of my qualitative study, which I haven't quite finished or published yet, which is by overvaluing biomedical needs over social needs, we can cause harm to patients. If we do not create space in medical encounters for addressing the biggest contributors to patient health, we can cause shame by delegitimizing the day-to-day struggles of patients. Often we can simply add to their problem list by piling biomedical problems onto existing socioeconomic ones. This is tricky because these patients are at increased risk for adverse health outcomes. However, we have to be very careful about medicalizing these issues. And we must think very carefully in our professional cultures about labeling patients as difficult or non-compliant, because it does not help us create a positive environment for helping them. And whether we see patients in acute or community settings, we can identify appropriate action plans for both acute and chronic risk factors and needs, including needs related to social determinants of health. We can do this. Here's an interesting study on interventions. 244 low-income hypertensive patients, most of which were Black, this is an American study, were randomly assigned to 3 groups. Routine care, which is hypertensive care from a physician. The second group was a health education intervention. This is probably the level of care that most of us are familiar with. Routine care plus weekly meetings for 12 weeks run by a health professional to help people get their blood pressure under control. And finally, the outreach intervention. Lay health workers were trained with over a month of training to deliver these services and provided home visits in which information was certainly given on hypertension, but more importantly, there was space created to talk about family stress, financial strain, and employment. And direct assistance was given if those issues were deemed relevant and acute. After 7 months of follow-up, patients in the outreach group were more likely, so this is the third group that had outreach to the community and additional socioeconomic intervention. They were more likely to have their blood pressure controlled than patients in the other 2 groups. They knew twice as much about blood pressure as patients in the other 2 groups. Those in the outreach group were more knowledgeable with more successful blood pressure control compared to the other group. And they were more compliant with taking their hypertensive medications than those in just the health education intervention group. And most compliers in the outreach group were twice as successful at controlling their blood pressure. So there is a role for this. Very briefly, Impact BC, I'll skip ahead 1 slide. Impact BC founded a project called Basics for Health in 2012 that was based on a very successful model in the States called Health Leads USA, which uses volunteers to act as resource navigators for patients. Some visionary insight at Impact BC funded a pilot project which subsequently lost its funding, but we were able to transition it and founded a nonprofit society, Basic for Health Society, earlier this year to deliver the same service. It's operating at Reach Community Health Center in East Vancouver currently. We're about to launch next week with Pain BC, a province-wide program to help connect chronic pain patients with social resources. And here's our vision and mission. I'll just reach through the mission for you, is to provide individuals and families with connections to resources and facilitate the resources they need to be healthy, to partner with healthcare providers to help them address the issues that sometimes health providers feel inequipped to address, and most importantly, to train the next generation of health providers as compassionate, non-judgmental, and skilled practitioners who are able to address both medical and also social issues. We work through this cycle of assessment, intake, matching with resources, and follow-up. And just one final slide, which is a vision that we hope to carry forward with Basics for Health Society, which is how to translate this to systemic action. We can do our best to reach people and connect them to social needs that are available in the community, but there are gaps, and we need to do something about it. We want to track this and translate it to systemic advocacy, which I believe we all have an obligation to do as part of our profession. And that is also reflected in population health research, which this graph alludes to. Countries do better not only because they have less income inequality, but also who spend more on social programs relative to the amount that they're spending on medical spending. With the orange dot on the slide, we can see that Canada spends a relatively low proportion of its GDP on social services, and this is decreasing annually. We can be assured that this will translate to worse health outcomes and higher costs if this trend is to continue. So let us call out for a poverty reduction plan. BC is one of the few provinces that doesn't have this. In May of this year, Nelson Creston MLA introduced Bill M212 into the legislature, which is the Poverty Reduction and Economic Inclusion Act. We should all throw our support behind this to help reduce the health impacts of people living in poverty. And finally, the food bank use that is escalating, especially since the recession in 2008, is important to mention given that today is World Food Day in Canada. And so my final question for you will be, who will join me in the Welfare Food Challenge? Starting tonight, I am going to eat for the next week on the welfare allowed amount for food, which is $21 for a week. So I challenge any and all of you to join me in this challenge. And if you're not up for it, please sign the petition calling for increasing rates to help lift people out of poverty. Thank you so much.
Thank you, Vanessa. We're going to open the floor for a couple of questions now. So if people have questions for Dr. Brcic, if you could go to the microphones, that would be great. I'm wondering, to start off the questions, if you could give me some ideas of how to approach a problem that I have, and that is that I work hard to try to get as much financial resource for the patients that I'm dealing with, but I'm met with a lot of paperwork and a lot of red tape. And I know that there has to be a better way to actually get the system changed, but I'm not sure what this one person can do.
Thank you for the question, Eileen. So any of us who have completed forms for patients know that there's certain language that's required in order to get things approved. Fundamentally, our responsibility is to tell the truth and to tell the truth about the health needs of patients. And so we can do that. And if you start to learn about the language that is sought in these forms, if you can learn from, partner with your patients to learn about forms that are rejected and why, a phone call to the ministry can do amazing things, and also sharing within your networks can do amazing things. Unfortunately, within the system are tremendous barriers to accessing services that the government has deemed appropriate for people living in poverty. And so not only can we learn how to make the system work and actively talk about it with your colleagues, but furthermore, we have to translate this, as you said, to systemic action. You know, I was on disability for years, and navigating health and social services for myself for that time was difficult, and I'm a physician. And so I can only imagine that people who are less familiar with how the health system works, I just understand what those barriers are like. We absolutely need to stand up for these patients, take the time to do so, and tell the ministry what we think about the accessibility of their programs.
Thank you very much. I wish you hadn't mentioned that I was an actor before. Please try and take me seriously this afternoon. Actually, yesterday I presented to a group on fetal alcohol syndrome, and as the Deputy Provincial Health Officer watching over 4.3 million people on all the various disease entities and programs across the province, it is hard for me to keep some of my slide decks up to date. And a physician came up to me and said, you know, some of your data is out of date, and you really should update it. And so today I took out every slide with any kind of demographic or health indicator data. So today I really wanted to just leave you with some ideas and stories and some impressions of my work in Indigenous health. So I titled today's presentation Partnering with Aboriginal Communities and not Partnering with Aboriginal Clients, because I think the idea of thinking of families and communities is much more helpful to us, because you are actually the experts on working with clients. You're working in the front line clinically, I'm not. And the idea of a community is an important one for us to consider. This is a very poor picture of an island in my territory. We call it Sisaye. It's called Savory Island. And Savory Island is near the town of Powell River. And the island is almost literally cut in half down the spine of this snake, as it were. And on one side is some of the most expensive real estate in the country, and thus the world. And on the other side of the island, it's reserve land. It's crown land held in reserve of my people. It used to be part of our, well, it's still part of our territory. On one side of the island, the real estate has postage-size stamp pieces of land with a sewage and water system and little tiny cabins. And on the other side, there's no sewage at all. In fact, there's not even a little cabin. We've kept it in its old condition. And on both sides are very beautiful, long, sandy beaches. And I think it's the perfect metaphor for partnership, in that I think First Nations people and non-First Nations people living side by side might have different ideas on how to be good neighbors with each other, and might even have different ideas on what's a good usage of lands, territories, and resources. Also, it's an island that I spent a lot of time on as a kid. My dad knew that I was good at school. He would pull me out because when he and my mother got married, they met in residential school. My mother made him a fish when they were married. She made him fish head soup. And she had been away in residential school her entire life, from 3 until she was 18. And she didn't know that when you cooked a fish head, you're supposed to take the gills out. And my father's grandmother said, "Where did you find this woman? She doesn't even have a child's knowledge of how to survive here." And for my dad, teaching me what a man needed to know to live in his own land was important. And so they needed each other. My mother could speak English perfectly. She could read and write. My dad knew how to live in this territory. He couldn't read or write. And so they together had a foot in both worlds. And I think it's for me, a metaphor that I need to keep my traditional knowledge. I'm really not ready to give up everything that I come from so that I can live in this modern society. So we know about Aboriginal people in Canada. We know from old publications like the Royal Commission on Aboriginal Peoples that Aboriginal people have the worst social and economic outcomes of any ethnic group in the entire country. We used to own everything, now we own hardly anything, and we are the last to benefit from the great wealth of this country. Incidentally, the Royal Commission on Aboriginal Peoples was used in a custody case between an Aboriginal and a non-Aboriginal parent. The non-Aboriginal parent argued that the Royal Commission shows us and tells us that Aboriginal and First Nations communities are inappropriate and unsafe places for children to live, and thus they must award custody of the child to the non-Aboriginal parent. And so these old views of Aboriginal people as our poor cousins who should know better and should do better is a bit antiquated and is insufficient. And part of my job as someone from First Nations community is to remind us that those old reductionist ideas are not a complete story, that actually my view of Aboriginal people and First Nations communities is one of resilience and strength, and of people as wonderful and as able as anyone here. This is a picture of an elder from my home. She didn't go to residential school. I was asking her what it was like to not have to go to a residential school. She was on the run like my father was. They lived in the bush and lived in our way. And she literally said, and I say this because I really don't want to tell you things that are so sweet, they're impossible to be true. She said, we had nothing to do but help the people. And that as a child, she learned about service, that she was sent out as part of her growing up and her growth as a person to help people and do whatever needed doing, whether it was to draw water or to carry wood or look after children or to deal with emergencies like a child being born. She would go there. And I was reminded of this when I was working clinically. Once I was in an Emerge, and I was trying to impress an elder, and I was saying, oh my gosh, I was so busy in Emerge. We had a car accident with 3 car crash victims in Emerge who needed assessment, and we didn't have 1 heart attack. We actually had 2 heart attacks and a stroke, and we had all the usual diarrheas and kids with runny noses and coughs. And can you believe it? An old woman asked me to go and get her a glass of water. And she said, oh, maybe she thought you were there to help. So I want you to keep that in mind, to do what's sensible. In British Columbia, we have many different First Nations languages. In this province, we have phenomenal diversity in First Nations. About a third of the languages in the entire country are here in this province. 203 different First Nations. That's 203 different chiefs. That's a lot of chiefs to listen to in my work, a lot of communities to think about, and 250,000 people. We represent about 5% of the population. So 1 in 20, I would think, of your clients, at least, or I would hope, 1 in 20 of your clients are Aboriginal people. And our historical inheritance, whether we like to talk about it or not, or it's just too difficult to contemplate, means that our health has altered since the arrival of visitors. What's more natural than immigration? Having just been to Hawaii and coveting that beautiful paradise, I get it. Who doesn't move around and look for a better way of life? But there are historical factors that have affected Aboriginal people. And so yelling at clients and saying, why didn't your mama teach you how not to do this? We can look back at some of these factors. And these factors are historical, but they're contemporary as well. The reserve system. The number of times I get asked, why are you living on reserves? Aren't they horrible places? And I say, we didn't ask to live on reserves. We were put on reserves. The loss of our traditional territories, there's still pressures on our traditional territories. The loss of our fishing and hunting sites and stocks, which continues. Pressures on our water system, the dominance of Canadian foods, alcohol, cigarettes, drugs. There's just a litany of issues that have plagued us for, well, at least 6 generations and still continue. So, in looking at diseases like HIV or cancer, if we could cure cancer and we returned our patients to their lives, and I worked in the downtown east side for 5 years, if I could cure their disease, and sometimes we could, and we would return them to the streets, had we done everything we could so that they could be well? Well, in British Columbia, we have something very unique. We have a formal commitment between the provincial government, the federal government, and First Nations governance to look at health inequities, that we have a shared commitment and a shared responsibility to change outcomes. And we even talked about the immorality of health outcomes being determined or partly determined by race as not sustainable and not desirable. And we mustn't allow this to continue, and so some of us spend our time looking at issues like health inequity or inequity in general. But this shared commitment, this formal commitment, is important, because before we used to have an informal commitment. I know that all of you are committed to all of your clients. You don't say, I want to give good service to everyone except for that you want to give good service to everyone. And so when we asked the province, and I used to work with the First Nations Health Authority, when we would sit at a negotiating table and ask the province and the federal government, how is it going in Aboriginal cancers, for instance, they would say things like, oh, don't worry, we've been dealing with cancers, as say the BC Cancer Agency, for a long time. We spend a lot of money doing it. Leave it to us. We're taking care of Aboriginal clients as they come in. And we said, well, actually, we'd like to have a little more in-depth discussion than that. You're reporting to us, because of our reciprocal accountability, your reporting to us needs to be more detailed than, oh, don't worry, leave it to us. So we signed a number of agreements. The agreements are not that important, unless, of course, you're working in jurisdictions where you need to have an agreement to work with a local Aboriginal group or a local First Nation, or maybe even a grouping of First Nations, or maybe some of you work at a high enough level where you want to have memorandums of understanding or letters of expectation between you and another service organization who deals with Aboriginal health issues. What's important is that we have formalized our agreement. And that meant that as a health practitioner, I was spending time negotiating who was in charge of what. I just wanted to look after people, but I ended up talking about who's in charge of what. So we have something called the Transformative Change Accord, a First Nations health plan. It's actually not that long. It took us many, many years to build, but this document is only about 18 pages long, and the commitments on them are literally only 2 pages, and they're numbered. They go to about 35, and there are additional, 25, and there are additional 8 that happened when the federal government signed on with us. And the commitments are very general to try and reduce specific health inequities like life expectancy and infant mortality. So the bilateral plan between the provincial government and First Nations, and this was, First Nations were represented by their chiefs, 203 chiefs and the provincial government, agreed to look at these areas: governance, relationships, accountability, health promotion and disease and injury prevention, health services, performance tracking. Very easy to say these, very hard to execute them. The most important part of it for me was around governance. Governance. Who's in charge? It was very apparent in issues like communicable diseases or cancer, where the province had been the lead for a long time, and First Nations people said, we don't necessarily want a First Nations BC Center for Disease Control, and we don't necessarily want a First Nations cancer center. You're good at cancer. We don't want to be delivering chemotherapy or doing surgeries. You're the lead. We'll follow you. But there are places where we're the very natural lead. So just to put it in a very simple way, when grandma has a headache and she needs aspirin, maybe that could be dealt with at the local level, that the local First Nations workers or the local family heads or the local caregivers could have some control over those resources. Because the old model, and you'll laugh because it's so silly, the old model was a doctor would write a script or a nurse would say, I'd like to give you some aspirin, but I actually have to call Ottawa or Vancouver and get clearance in order for me to give this to you. That's how bureaucratic the old system was. And so a clerk, not a healthcare professional, a clerk would make a decision whether an Aboriginal grandmother would get aspirin or not. And there were so many steps, and it was so time-consuming that by the end of the process, by the time grandma had 2 aspirin in her mouth, that bottle of aspirin cost $80. So there was this profound inefficiency in governing Aboriginal people's health and keeping it out of their own hands. And so some of those services were moved closer to the front line and given over to communities. So that's a very simple story about how services were transferred over to some First Nations groups. And again, a very poor resolution photograph of a baby. Out of our hundreds of meetings, the one that I remember the most was around the return of infant bodies to First Nations communities. Like in the event of a sudden infant death, a baby, and in meeting with the chief coroner and chiefs, the chief coroner said, well, you know, by the Coroners Act, by BC law, I am allowed to keep an infant's body for as long as we deem reasonable in order to determine a cause of death. And I remember one of the chiefs slamming their fists on the table and saying, we know that you think you're in charge, but those are our babies. Those are our families. And it really drove home to me why First Nations people need to be stakeholders in their own health, and not just the government, and not just the professional, and not just, in this case, law. And thank goodness the chief coroner was very kindly, and she saw the sense in that, and she said, yes, of course we must bend and do our best. And the letter of the law is one thing, but humanity and sensibleness, if that's even a word, are something else again. Last of all, there are a list of challenges, not that I think you should be interested necessarily in the minutiae of the challenges of what we're doing. I just want to make a couple of points before I finish. And one of them is that partnerships, standing together and agreeing that Aboriginal and First Nations people are deserving of help, deserving of our expertise, deserving of our services, is actually quite a challenge. And so we're out and about and asking people to look at that. And that in a number of areas we have initiatives. And so we ask simple questions that are hard to answer, like, can we track, can we comment on kidney diseases in First Nations and Aboriginal communities? And in order to answer that question, can we track these data, we need to speak to more than a few stakeholders, including the people who are, whose data that belongs to, including the data gatherers, including the caregivers, including the data stewards like the government who track those data. And not only should we be asking, can we track Aboriginal and First Nations kidney diseases, can we commit to improving those outcomes? So once we can finally measure some of the outcomes in your work, can we together commit to improving those very first numbers so that we can feel good about what we're doing? Last of all, I wanted to say that once I was in a First Nations community, there was an elder there who I loved very much, who I remember from my boyhood, and I ended up looking after her. She had an arrhythmia, which was symptomatic, and we were worried that it would degenerate into a fatal rhythm and she would die. And she was literally the oldest woman in the village. And she said, and the physician I was handing over to at 10 minutes to 5 on the Friday when I was supposed to be leaving that hospital, he said, we can't keep you here in this tiny hospital. We don't even have a heart monitor. We have to send you to a CCU or an ICU. We have to send you to Vancouver. And she said, no, I am ready to die here in this place where I've always lived, where I was born. Please don't send me. And he said, I really have no choice. I have to send you. And I said, I'll stay. I'll be with her. I'll monitor her. And if something goes wrong, I know what to do. So I sat with her all night, just holding her wrist there, checking her pulse to see if anything was going to change. And around 7 a.m. the next morning, her rhythm spontaneously converted to a normal rhythm, and she was fine. And many, many months later, a man came up to me in the street, and he said, you saved my grandmother. Do you remember that night? And I said, no, your grandmother got better by herself. I just sat with her. And he said, no, you saved her. And she lived for, a long time after that. And I said, please don't say that. That makes me feel so uncomfortable. It actually makes me feel bad because, I did nothing at all. And he said, no. She said she didn't want to die on that young doctor's watch and scare him to death. And she willed herself to live. And I was so moved by that, by her, and I was reminded that the point of all of this is not to be big, fancy, important caregivers, but to be the extraordinary human beings that our clients often are. The extraordinary human beings, that our families and our forebears would be very proud of. Thank you.
Thank you, Evan. Any questions for Evan? I have one if you're thinking. So I'm just wondering if you can comment on what you can think of that we might be able to do differently to actually be providing more culturally sensitive care. I mean, we put beautiful First Nations pictures on our walls, but I don't know that that's actually changing how we care for First Nations clients.
Okay. Rather than giving you something concrete like, Aboriginal clients can be very slow to speak to you, it's more that some Aboriginal clients, and I mean some, because they're very diverse, some are hard to reach and hard to treat. And rather than thinking of self-reflection, as in, like, why am I feeling like this in this moment, I think that we need to be very kind to ourselves and say, this patient may be hard and may take a lot of space and time in order to help, and I will be kind to myself and give myself that time and space in order to help this client. And like I said before, to do sometimes what is sensible, even if it feels a little bit like it's outside of your training or your work plan. Thanks.
Thank you very much, and thank you, Ben. Thank you to everyone who is here today. I guess I will get started, and I want to make sure that there's plenty of time at the end for questions or comments or feedback. I don't want to pretend that I have the answer to every single issue, but hopefully this discussion will provoke further discussion amongst all of us. The objectives of today's presentation are really to revise existing practices and to develop new strategies to overcome LGBT barriers to accessing dialysis care and consistent treatment. And even though I am a renal social worker, I have tried to design this presentation for all of us who do work in renal services, those of us who are on the front lines with patients every day, whether you be a nurse, a technician, dietitian, nephrologist, and those people in administration as well too. If nothing to disclose, that's something I just usually put in the presentations. No, I am not being bought out or paid by a pharmaceutical company or anything like that anyway. A side note, I suppose disclosure about this presentation, there is some discussion about sex, so I hope that doesn't offend anyone. I don't think it will, or else you wouldn't be sitting here anyway. All right, let's start with some definitions. LGBT versus GLBT versus LBGTQAP versus gay. There are many acronyms out there. I'm sure you've seen many different versions of this. When I say LGBT, lesbian, gay, bisexual, transgender, some people put gay first, gay, lesbian, bisexual, transgender. This next one, actually, I try to throw a bunch of acronyms in there. The QAP. Q, does anyone have an idea what that is? Queer or questioning, people that are questioning one's sexuality. Asexual, or P, polysexual. There are probably more terms that could be used as well too. And what's the difference? There is a difference depending on what audience you're talking to, what context you're talking about too. But for this presentation, I want our discussion to be about sexual minorities in general, and I don't want anyone to feel excluded from this, and I want us to think about all of our patients that we do have. Another thing with definitions too, I want to differentiate sexual orientation and sexual identity, which are two different things. As an example of this was sexual orientation. Okay, I identify as gay. Sexual identity, I identify as a man. So there are two separate issues that we're going to look at as well. Oh, Canada. I love that picture too. Canada is consistently ranked as one of the best nations for LGBT equality, with Vancouver as a top city. And I want to let's get to the next slide. And let's look at other parts of the world to compare Canada to. I'm not going to go into too much detail about other nations, but 81 nations around the world criminalize homosexuality, and 7 of those allow the death penalty for consensual same-sex relationships. And this isn't even including Russia with its anti-gay propaganda law, which there's been a lot of talk about recently, especially with the Sochi Olympics, with people that were boycotting that. And even how Canada is different than the US, where I'm from. When I've given presentations in different regions of the United States, I've had to tailor what I've discussed based on what legal protections there are out there. In the US, it's kind of like a patchwork quilt of gay protections, depending where you speak. In New Jersey, where I'm from, I know, please don't hold the stereotype of New Jersey against me. There's more to us than The Sopranos or The Real Housewives of New Jersey or the Jersey Shore or whatnot. Like, I hope I'm not crass and rude like that. Anyway, but New Jersey, as far as states in the U.S. goes, is very progressive. When you look at Canada as a whole, there are protections based on sexual orientation on the federal level since 1995. British Columbia actually has been on the forefront of protections also. There are not specific transgender protections on the federal level in Canada, though individual employers or individual municipalities do have protections based on sexual identity. And Canada has become an international safe haven for LGBT immigrants. And I think that's important to look at as well, too, with a very large immigrant population in the Vancouver region itself. There are people from around the world that have been persecuted for who they are, that have immigrated here to Canada. And let's look at some LGBT barriers to accessing health care. There could be a fear of understanding. I guess let me backtrack a second too. When I talk about the barriers to accessing health care, these are possible issues why LGBT patients may not be seeking the health care that they do need. A fear of understanding who they are, who they live with, who they love. Fear of acceptance. From a Kaiser Permanente study from California, 8% of LGB patients, the lesbian, gay, bisexual patients, report having been refused healthcare based on their sexual orientation. 19% of trans patients, patients that are transgendered, whether it's pre-op or post-op, report the same. 50% said doctors in their area lacked cultural competency to care for LGBT patients, while a whopping 90% of trans patients cited this concern. And 50% of trans patients reported that they have had to teach their provider on their health needs and resources. From Statistics Canada, lesbians and bisexuals were more likely to report unmet healthcare needs than their heterosexual counterparts. And another barrier for LGBT patients when it comes to dialysis and renal services could be an avoidance of nephrology follow-up. I know we all see differences in our patients as far as preparation goes. Those patients who have been following their kidney care with a nephrologist versus those that have no idea that they are in renal failure. We look at the differences like patients that start dialysis with a fistula, that have expectations of what dialysis is, why they're on dialysis, and self-participation in that as well too, versus the patients that are acute, new, that had no idea what was going on because they didn't see a nephrologist in the past. I want to look at the top 10 clinical mistakes that many of us make working with LGBT patients. One, a lack of self-disclosure if directly asked. And this can be a tough one as well, too. As a healthcare practitioner, we're often taught, no, we don't have to divulge many specifics about our own lives to our patients. And I certainly think that comfort has to be your guide with this. But if you are directly asked by a patient regarding your sexual orientation or your sexual identity, what would you do? Would you discuss that? Would you be honest? Honesty can help to diffuse tense situations as well too. Even if you are asked and you answer you are heterosexual, at least you're being honest about this as well too. Number two, denying internalized heterosexism or homophobia. And I ask, what's the difference between external and internal heterosexism or homophobia? I guess I'll give some basic examples of this. An example of external heterosexism could be a mom saying to their young son, you need to get your hair cut or everyone's going to think you're a girl. Versus internal, talking with the gay man who is uncomfortable or ashamed of seeing lesbians kissing. Or another example could be as well too with external homophobia, being in a region, in a district where legally it's okay to discriminate against LGBT people, versus another internal version of that, a lesbian who is ashamed of effeminate men or drag queens. Number three on this list, not knowing LGBT resources in your community. Learning where the community centers are, like here in Vancouver, the Community Resource Center in the Davie Village offers a great deal of services and information for people and our patients. Legal services, media, like Extra Vancouver is a gay newspaper here in Vancouver. Counseling, counselors who actually are well-versed in working with LGBT patients. Gay-friendly businesses. ASOs, AIDS service organizations as well too. This could be very beneficial for patients that do have AIDS or are HIV positive, looking at services that can support dietary needs for people that are malnourished, undernourished, transportation issues, medical support as well too. If you're working with the patient who does have AIDS, who is HIV positive, we want them to be able to have an infectious disease specialist that they're working with. Number 4 on this list, using the wrong terminology with your patients. There sometimes can be an urge to be over-clinical in terminology when working with patients, saying things like the homosexual community or talking about one's sexual preference, which is a pretty outdated term to use. Sexual orientation is not a preference, versus queer. I didn't actually mean to put 2 stars there, but when I was trying to send this, is funny, from my work email when I'm putting this together, the word queer is filtered out as an obscene word, which I thought was kind of bizarre as well too. So that's why the 2 stars are on there. But again, some people are offended by that, by the use of the word queer. Personally, I don't really like that word. I don't suppose that I would be offended by it, but I don't refer to myself that way or to other people. I think this is kind of like the idea of other minority groups that have embraced derogatory language, like the N-word for a black person or the F-word for a gay male as well too, that some people are not offended by it, but you need to really be aware of who you're talking to and what their feelings are on the matter. Number 5, not knowing the stages of coming out. And there are stages, and there's not exactly a set time period where someone has to go through these stages, bam, 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 in a certain order, like 2 days on this, 3 months on this. It's not like that, too. But being aware of this, and I don't expect anyone to have this memorized as well, too, but looking at the stages of coming out, the confusion stage, confusion about one's sexual orientation or sexual identity, comparing to other people they know, especially children, teenagers, that people in all stages of life can certainly come out. Acceptance, accepting one's sexual orientation. Yes, I realize I am gay, or I am bisexual, or I feel transgender. Pride, being proud, yes, of where someone is, how they do feel, but seeking out company of people who are in the same situation of them, almost exclusionary maybe to being members of society as a whole. That's where this goes to synthesis. Synthesis is looked upon as being the last stage of coming out, where yes, everything else comes into play. You do accept who you are, you're proud of who you are, but you realize you're a member of society. Not everyone is going to be gay. Not everyone is transgender. Not everyone else is lesbian. There are heterosexuals out there. And realizing that we're all in the same situation together. And with coming out, actually, I want to stop for a second too. And I want you to think about the dangers of coming out for your patients, or your coworkers as well too, because this is a very sticky situation for a lot of us who are working in healthcare, working in rental services. And we look at some of the dangers that patients may face who are not comfortable coming out about their sexuality, their sexual orientation, sexual identity. Coming out can lead to very inappropriate questions of disclosure. Why don't you have kids? Well, you're not married. Yes, gay marriage has been legal here in British Columbia for 9 years, but there's certainly a lot of people that are LGBT that are not in married situations. Or yes, there are gay people who do have kids. There are many that don't as well too. This leads to questions that can be uncomfortable for patients to have to face. There can be avoidance of services as well too for patients that are afraid to come out, afraid of what reaction they're going to incur from their healthcare providers. There can be the fear of unequal treatment. I'm lesbian, I'm very open. I want to be open about this, but I don't really want to see my doctor because I don't really want to talk about this, and they're going to look at me differently. That's an issue with the fear of unequal treatment. Or there can be an automatic assumption of a problem of diagnosis. As a gay man, there could be an assumption, oh, has HIV been discussed? Has AIDS been discussed? Well, that's not an issue for every single gay man. I don't want to minimize the importance of seeking services if you do have AIDS or you're HIV positive, but this becomes an automatic assumption. Or someone who is transgendered, oh, you must be really screwed up mentally. You have a lot of mental health issues. Well, maybe, maybe not. These aren't issues that are guaranteed. And I think when we look at our coworkers as well too, just think about what kinds of dangers are out there for our coworkers about coming out. Could mean loss of a promotion at work. For someone who is transgendered, if there's not actually something in place protecting their job, it could mean the loss of a job. Loss of interpersonal relationships with coworkers or with patients, or working with patients that might be hostile towards you. Or also being in a situation where you are the forced example or the forced stereotype. Well, all right, you had the gay perspective on this and being turned to in that way. Well, who's to say that you had the perspective for every gay person? Number 6, not understanding mixed orientation marriages or relationships with bisexuality and polysexuality. There can be a great deal of judgment from people regarding other relationships, looking at someone who maybe identifies as gay, as a gay man who is married to a woman, but it could be, or vice versa as well too. Is I think putting labels on there and not trying to understand where a patient is at and just going off assumptions. Number 7, being a blank screen. I know as a social worker, I was taught to try to not show a lot of emotion when patients do come to me with issues, with problems, things that I might find shocking at times as well too. But I think there's a difference between being judgmental and being a total blank screen, where someone comes to you if they're talking about their sexual orientation or issues with sexual identity, and your reaction's just, you're a person. And I think being engaged in a conversation is crucial in having your patients feel comfortable. Number 8, and this is a biggie, not acknowledging that gay adults were once gay kids, or conversely, gay seniors can still have sex or have desires. I know with gay seniors, some statistics that are out there, gay seniors are twice as likely as straights to live alone. And I want you to think about, what are the implications of coming out later in life or not at all? There was a great article that was in the Toronto Globe and Mail that came out last week about gay seniors and how many gay seniors that have moved to senior housing communities have had to come out all over again. And there are a whole host of issues of coming out in a situation where people may be hostile towards them or towards their relationships. Think about internalized homophobia that patients may be going through, or patients that grew up in a time where they were not open to discuss issues about their sex, sexuality, sexual orientation, sexual identity, and what feelings are they dealing with. And then looking at what resources are there for our patients. When it comes to seniors and sex, so this is a little story. When I was a social work intern many years ago, and I was 22 years old, I worked in an AIDS service organization in Philadelphia, and one of the things that I had to do was to facilitate a support group for HIV-positive people over 50 dealing with sexual issues and sexual relationships. At that time, I was 22, and I thought 50 was pretty old. And I thought, ooh, yeah. How am I going to deal with this? I'm thinking, Aaron, these people are older than my parents. Like, oh, I felt so uncomfortable with that. And I was forced into the situation where we had to have open discussions, and I became more and more comfortable with that. And now at this point, 50 just certainly doesn't seem old to me anymore now, but at that time. So I think going through that as a clinician, being in a situation that was uncomfortable for me, has helped me over time in talking about sex and sexual issues. On my top 10, again, number 9, not having any LGBT-friendly literature in your dialysis waiting room or lobby. Whether this be the newspaper like Extra Vancouver or any kind of free-thinking weekly newspaper or magazine articles that are open about LGBT issues. These are all things that can help patients feel comfortable in your clinic coming for dialysis services. And along with this too, an issue that I've had in New Jersey at our clinic, I live in the suburbs of Philadelphia. with our television, our first shift in the morning begins at 5 a.m. Before I'm there. And in the lobby, there had been the Tuesday, Thursday, Saturday schedule. I know all the players involved with this now fight about what to show on the television in the lobby. Fox News in the U.S., which I'm sure you see from Seattle as well too, is very conservative. MSNBC is very liberal, and there have been huge political fights among patients in our lobby that have become so heated they become very inappropriate. So that's something just to be considerate about also. Number 10 on this list, believing that straight and gay couples are the same. Many of us think, okay, well, we work with a lot of straight couples and gay couples, you have the same issues. Well, maybe, maybe not. There are many differences to look at. There are not necessarily set male roles, female roles in same-sex relationships, and I think sometimes just going off assumptions can be harmful. Want to move along, and certainly as you have questions or comments, please, like as we get to the end of this as well, I certainly would like to hear that. Looking at some clinical tips for working with transgendered clients or transgendered patients. Again, from Kaiser Permanente, from a study that was published, 26% of trans people surveyed experienced physical assault or intimidation by a healthcare professional, and 10% cite sexual assault. When I first read that, I was shocked by that. And that just provoked some thought in me as well, too, about a whole nother layer of discrimination that trans people are facing. From a Vancouver Coastal Health study, Vancouver Coastal Health has a great program on working with transgender mental health issues. It's one of the best published departments in North America. 72% of trans people reported difficulty in accessing mental health services, and most agencies outside of Vancouver in Victoria have little or no experience in working with transgendered issues. That's important to just be aware of, especially for those people in British Columbia that are not here in metropolitan Vancouver or in Victoria. Being aware of what services are out there for your transgendered patients, and how for people that see patients every day in the front lines, social workers, the nurses, technicians, we, in a way, almost by default, become the mental health backup for these patients. With transgender patients, too, use transgender affirmation language or affirmative language. Looking at pronouns that we use. He, she, should we use gender neutral pronouns? What should we do? I used an example of really finding out where a patient is at to see what would be the best language to use. Going back to my first social work job years ago after social work school, I worked at a mental health agency in Philadelphia with many LGBT patients, people that were living with HIV, and most people with a substance abuse issue. I would also do intakes for the agency for people coming in, whether they would be seeking individual counseling, group psychosocial rehab. We had a partial hospitalization program. But I would work with the patient, do a full intake to refer them to our psychiatrist. And for the most part, there are some questions I didn't really have to ask. I just would automatically check, like someone's gender, like male, female, what have you. I would just go through without asking, without saying anything. The first transgender person I did an intake with, I didn't know what to say. And I really thought about this, like, well, how do I do this without being offensive to the patient? I asked all the hard questions well, I saved that. That should have been an easy question towards the very end. I kept thinking in my mind, how am I going to put this? What should I say? And I ended up saying to the patient, asking the patient, with which gender do you identify? And that opened up a whole discussion. The patient was a trans woman, was born a male, and was actually, it was pre-op transgender to becoming female, but the patient, she identified as a woman. And that opened up a whole another discussion. I got the patient's perspective on that without assuming anything and without putting too much of myself into this, but seeing where was the patient and what did she want to be referred to as, what language would she like me to use. When working with transgendered clients and also with LGBT patients as well too, we can look at expanding the definition of family when we're working with the patient support system. I don't know if anyone here is familiar with the Tales of the City books by Armistead Maupin. If there's some people that have been familiar, there's a great miniseries that came out years ago, about 20 years ago as well too. The first book came out 40 years ago, and I think the last book just came out this past year. They're great books with a wicked sense of humor, some deliciously nasty things in there. But one of the central characters is a transgendered woman. And she uses a term that I read this and I just love it, when she talks about one's biological family versus their logical family. Logical family, who do you choose to be part of your family? And that's important when we look at a patient support system, who is in their lives, who is truly important. It doesn't necessarily have to be someone who was blood related to them. We can try to understand what is transphobia. From TransPulse, which is a service in Ontario, 75% of trans people in Ontario have seriously considered suicide. There is a great amount of transphobia in society, even among the LGBT community. Acknowledged in males to females a loss of societal male privilege. I think we all understand what the glass ceiling is. Not even talking in LGBT terms, but for men versus women, societal expectations, what comes along with being male, what's easier being a male, and from someone who was born a male who then becomes a female, they lose that societal male privilege, and that's often an issue that's overlooked. And there's very, what am I trying to say with this? There's pressure to fit into a very narrow gender binary for someone to be male or someone to be female, and not understanding the transitions that do exist with that. And we also need to look at understanding the mistrust of professionals. Overall suggestions to help our LGBT patients. Never assume that your LGBT patient is out of the closet. Ask. And again, asking our patients is important to find out so much about them, not to go off assumptions. Ask your patient if it's okay to use certain words, like he or she, or when you say LGBT, some people are offended by that term. Find out from your patient if they're okay with that. Or ask for clarification if your patient uses a term that you don't understand. There's nothing wrong with asking. Incorporate anti-discrimination policies into your practice. Advocate on behalf of your LGBT patients to others, including your other patients, and to your coworkers. Read up on LGBT current issues in history. If you look at current issues, if you look around the world, Uganda, Nigeria, Iran, where there has been a great deal of talk about laws that do exist or that have been proposed, criminalizing homosexuality, having a better understanding of that, looking at LGBT history, in Canada, in the US, around the world, how the LGBT rights movement has progressed. Continue your trainings in cultural diversity. There's always more to know. No one is truly an expert on every issue all the time with LGBT issues or beyond that. I certainly have a lot more to learn. With case studies, with this, I want people to think about this when it comes to the questions. If you have ideas, I just put these out there in their difficult situations and think about what would you do. Number one, Laura, a dialysis patient in the Okanagan Valley, is transitioning from male to female. She's not open about her transgender status and upcoming reassignment surgery. She'd answered female to questions of gender in every assessment, but her referring physician reports to the staff that Laura is in fact a male and lying to everyone. Think about that. What would you do? What do you think about that? What would you say? Number two, Wanda is a renal social worker in a unit on Vancouver Island. She's a strong believer in celebrating multiculturalism, and for Pride Month, she created a gay pride poster for the lobby of her clinic. Several patients complained to her that they were offended by the idea of gay pride and demanded to administration to take it down. Number three, Choi is a dialysis patient in Vancouver who is questioning his sexuality. He's afraid to discuss this with his family and friends. He feels very isolated. He confides in his favorite nurse that he doesn't know what he's feeling or what is wrong with him. I just want you to think about these scenarios with these case studies and how would you react to help your patients or to help your coworkers? And I'll ask for your feedback in a minute. With the resources, it's what I've used for this presentation, and this gets me to the end where I want to hear from you.
Any questions for Mr. Jin? Or for any of our other speakers? I do have one for Vanessa, or Dr. Brcic. Was it an MLA that took on trying to live on what welfare is giving? And was he trying to prove a point that they get too much? And what happened as a result of that? Because I didn't really get to follow it after. I knew he was eating like cup of noodles at the end or something, but you could speak to that.
So, at first I thought you were asking about the MLA who's introducing the Poverty Reduction and Economic Inclusion Act. That's a very positive thing that's happening. But I think what you're actually alluding to is the welfare food challenge that I mentioned at the end. So there is a lot of movement for a campaign called Raise the Rates, which is that we are entrapping people in situations of poverty and poor health by keeping very low minimum wages that aren't keeping up with inflation, as well as very low welfare and disability rates. And so to draw attention to this issue is the Welfare Food Challenge. And there was an MLA, I believe, in Surrey who participated last year, and I don't know the full extent of who's participating, but I've done this research for a long time and I decided to participate this year. It starts today. It's actually taken me a day and a half to figure out what I'm gonna eat on $21 for a week. So I'm still planning it, so I'm gonna start it tonight. The number of hours it's taken me to figure out how to make this work is tremendous. I think there was an MLA who did it last year in Surrey, but the whole point of the challenge is to draw attention to how impossible it is to live on such low wages. And if you go to the website, welfarefoodchallenge.org, it gives you the breakdown of how they calculated $21. That's based on a welfare rate of $610 a month, which is not enough to live on. But what they did is they calculated SRO housing rates in Vancouver, which is like $450 with a couple of other expenses for a bus pass. And the amount that they had left for monthly food was $84 for the month. They divided that by the number of weeks in the month and then rounded it up to $21 and put that forward as a challenge. Because inflation has risen, the Welfare Food Challenge this year is less. I think last year the challenge was to eat on $28, But because the rates have not changed and the food prices have gone up substantially, it's an even greater challenge this year. And it's impossible. So I think that I don't know the particular person that you're talking about, except that that's kind of the story of what's going on. And you can follow me on Twitter or on Facebook, and I'm posting updates about the food challenge, how it's going for me this week. So if anybody's up for joining me in that, I please challenge you to do so. But it's not easy, and I think that's the whole point of the challenge. I mean, my menu for the week is rice and lentils and oatmeal, basically.
Thanks for that.